Hello everyone, good afternoon. Today we will present a case at the Aorta Hub about an ascending aortic aneurysm. I'm Lorena Villalba from Buenos Aires, Argentina. This clinical case concerns a male patient who is 70 years old. As a cardiovascular risk factor, he has a long-standing history of hypertension, and family history indicates hypertension and arrhythmias on the mother's side. There is no history of sudden death in the family, and the reason for consultation is that he is attending the aorta center as an outpatient, referred for dilation of the ascending aorta, likely coarctation based on imaging studies requested by his clinical doctor. As for his usual medication, he was taking 20 milligrams of April daily, and the physical examination showed a blood pressure of 130 over 80 millimeters of mercury. His heart rate was 73 beats per minute, he weighed 75 kilograms, and his height was 1.75 meters, with a body surface area of 1.9 square meters. A regular pulse was seen with no T differences in the upper limbs versus the lower limb. At the cardiac level, a diastolic murmur was heard at the aortic focus 2.6, and at the respiratory level, there was good bilateral air entry without added noises. An electrocardiogram was conducted, revealing a sinus rhythm of 70 beats per minute and preserved conduction in the right atrium. A narrow area was observed with good air progression in the precordial leads, and there were no changes in the ST segment or T wave. A transthoracic echocardiogram was performed at our center, where the first video shows a long axis for the left sternal view, which is clearly visible. A dilation at the level of the aortic root can be observed. The ventricular diameters appear to be preserved within normal limits indexed to body surface area. These two images show the dimensions taken at the level of the Valsalva sinuses, and at the tubular portion of 40, it's 8 millimeters. This is a zoom at the level of the aortic valve and the mitral valve, where a slight fibrosis can be evidenced in the two-dimensional image, predominantly of the right coronary valve, and in the color flow, an aortic regurgitation jet can be evidenced with a predominantly central jet and eccentric jet. The next clip shows a short axis view of the great vessels, featuring the aortic valve prominently in the center with its impressive morphology. Tri-leaflet and a zoom at the level of the same, where we can also see the regurgitation jet in the dual color, featuring a central jet and two eccentric jets that seem commissural. In the next clip, we can see an apical 5-chamber view, a zoom at the level of the aortic valve, and we can also see the aortic regurgitation jet, which can be evidenced below the valvular plane, a linear image protruding towards the left ventricular outflow tract, approximately 6 millimeters away from the valve plane, potentially corresponding to a subaortic membrane. There is also a slight acceleration at that level. In this 3-chamber apical view, we can observe at the aortic valve level, beneath the valvular plane, the same protruding linear image that creates this slight acceleration at that level, and we can also observe the jet of aortic regurgitation. There were no signs of significant stenosis at that level. In these two images, we can see continuous Doppler at the level of the aortic valve, with a slightly increased velocity of 2.3 meters per second, and a pulse Doppler at the level of what is the left ventricle outflow tract, also slightly increased. And the subaortic membrane does not cause obstruction. In these images, we can see the pattern of transmitral flow and the filling pressures, which appear to be preserved, and the ventricular function, which is also maintained, with an estimated ejection fraction of 59%. The first image in the upper left corner displays the following. The diameter measured at the aortic arch level, reaching a maximum of 36.8 millimeters, As we observe, a pulsed Doppler at the level of the descending aorta shows evidence of diastolic reflux with a BTI of nearly 15 millimeters. There were no signs of coarctation in the descending aorta, and the abdominal aorta did not present any reflux signs, diastolic reflux. The patient had an external angiography performed, and in this video, which is a cross-sectional view, we can observe the dilation of the ascending aorta, the dominance of the tubular aorta, which has a maximum diameter of at 50 millimeters at the level of the tubular portion. A preserved diameter was reported at the descending aorta level. And additionally, they did not report signs of coarctation by this method, and the aortic valve was also reported as having a trileaflet morphology. Here are images in sagittal and coronal sections showing, as I previously stated, the enlargement of the ascending aorta, mainly the tubular part, and we observe that there are no signs of coarctation in the aorta. The descending aorta looks to be within normal limits. This is the report, as I said, noting a trileaflet aortic valve, enlargement of the aortic root and the ascending tubular aorta, measuring up to 50 millimeters in diameter, a 35 millimeter aortic arch, and the descending aorta segment showing preserved diameters. They also reported the extension from the aortic ring to the origin of the supraaortic branches measuring 14 centimeters. Thus, we have a 70-year-old patient with an ascending aortic aneurysm in the tubular section measuring 50 millimeters at its widest point due to a moderate aortic regurgitation of mixed origin, likely resulting from aortic dilation and valve degeneration. And we were able to observe that there is a subaortic membrane near the valvular plane that does not lead to significant stenosis and the presence of aortic coarctation. The patient was undergoing the initial studies that had been performed, thus it was discussed in a multidisciplinary setting concerning the aorta GIM, and it was determined that considering his medical history, the initial images taken necessitated follow-up and control in 6 months with imaging studies and a re-evaluation of the patient. And just to quickly review some recommendations from the guide published last year, it emphasizes the importance of managing a multidisciplinary team that includes participation from cardiologists, vascular surgeons and radiologists, and geneticists for the management of these aortic pathology diseases, as well as peripheral arterial pathology, and that it should be managed in a more holistic and integrated way for these patients. In the current state, and also as a quick review to go over the recommendations regarding root and ascending aorta surgery, well, as we know, any patient with a diameter greater than or equal to 55 millimeters, whether from the ascending fusion of the root or the aortic arch, obviously cannot remain untreated. There is no doubt that intervention is necessary, and as a new point that has already been discussed in the American guidelines, it is that in patients with ascending aortic dilation who have a low surgical risk and can undergo surgery in a center with adequate experience may be considered for intervention. Adequate experience intervention may be possible for certain diameters. It could be considered to intervene on patients with smaller diameters, such as those greater than or equal to 52 millimeters, with an indication, DOSA. They also suggest, albeit with less supporting evidence, that patients with dilation of the ascending aorta or root with a diameter greater than or equal to 50 millimeters and who also present a low risk and may show some of the subsequent predictive factors or high risk indicators for dissection. For instance, the yearly growth rate of over 3 millimeters a year, hypertension that cannot be managed with medication, a shorter height, and the root phenotype deemed malignant, let's say, if the aorta measures more than 11 millimeters. If there is a desire for pregnancy in women, or if there is a coarctation of the aorta. In these patients, surgical treatment might also be considered for smaller diameters based on an indication below 2B. This is somewhat of a program regarding the management or diagnosis of aortic dilation via echocardiogram. Clearly, when the diameter is 55 millimeters or more, it should be verified using a three-dimensional method such as a CT or MRI without question that those diameters necessitate aortic intervention. Even with smaller diameters, it is still important to try to, let's say, break time to create a three-dimensional imaging method to confirm that the diameters are correct. And also a bit for smaller diameters will go to depend a little on the phenotype as well, if it is an ascending phenotype or a root phenotype, and also a bit on the criteria for high risk dissection, as I mentioned earlier, and it will also depend on whether early surgery can be recommended or if we should continue reassessing every half year, and somewhat to provide a few concluding messages obviously highlight the importance of the multidisciplinary team's role in deciding the right time to intervene with the patient. Break time 0.5 to be aware of the latest updates from the most recent aorta guidelines and to grasp the idea of the aorta as an organ and as part of a system that needs a holistic focus integral and the participation of, as I mentioned, cardiologists and surgeons, radiologists and geneticists for aortic pathology management, and to know that intervention is recommended for diameters below 50 and 5 would be recommended, clearly depending on the specifics of each patient, and also knowing that the finding of an aortic aneurysm may indicate diffuse aortic pathology, so once the existence of one is evidenced, it is essential to assess the vessel in its entirety. It is important to understand that imaging studies, including CT scans, MRIs, and echocardiograms, should adhere to the recommended protocols for acquiring images, measuring and reporting the relevant aortic dimensions, as well as how often these should be done during preoperative monitoring and after the procedure. Thanks a lot.